My name is Guylaine Thériault. I'm a family physician and the chair of the Canadian Task Force. I will discuss today the draft recommendations on screening for breast cancer in Canada. To make the information accessible for this presentation, we sometimes rounded numbers and opted not to give confidence intervals. Estimates presented here are preliminary and based on the best available data. But like any data, they have limitations and some uncertainties. All details are accessible in our draft guidelines and other documents that you can find on our website. Slides like these will be made public after guideline release to help with dissemination, uptake, and implementation into practice. The views expressed here do not necessarily represent the views of the Public Health Agency of Canada. The task force is an independent panel of volunteer clinicians and methodologists. At the moment, on the task force, we have 6 family physicians, 4 specialists, and 2 nurse practitioners. Our mandate is to develop evidence-based clinical practice guidelines to support primary care providers in delivering preventive health care, with the goal to improve the health of Canadians. We decided to update the breast cancer screening guideline in a regular meeting we had in February 2023, and the work started in March 2023. Who was part of the working group? I was the chair. Natalie Slapcheva, a nurse practitioner, was the vice chair. We had 2 specialists, Jennifer Fleming and Scott Klernbach, 2 family doctors, Kate Miller and Ashraf Sheffin, and we were supported by the Public Health Agency of Canada, Heather Lindberg, Laure Tessier, Greg Traversy, and many others. Like for any of our guidelines, we did involve experts in this working group. The working group included a medical oncologist, a radiation oncologist, surgical oncologist, and a radiologist. We also had 3 patient partners on our working group, 2 with lived experience. All working group participants and all task force members declared having no conflict of interest or financial relationship with anything to do with breast cancer screening. In order to make the work happen, we had evidence review and synthesis centers that help with gathering the evidence, a knowledge translation team from Toronto, and a modeling team. There were also many other contributions by external stakeholders. We had an open portal on the summer of 2023, a knowledge exchange event in September 2023, and we have the task force patient advisory panel. Let us begin with some facts about breast cancer. Breast cancer is the most common cancer and second most common cause of cancer death in Canadian women. In 2024, it is estimated that more than 30,000 women will be diagnosed with breast cancer. It is also estimated that more than 5,000 women will die from breast cancer in Canada. What about breast cancer incidence and mortality? If you compare 5 years interval, 1984 to 1988, compared to 2015 to 2019, you see an increased rates of breast cancer in Canadian women. In the ages 40-49, 0.12 more per 1,000 women. In the ages 50-54, 0.32 more per 1,000 women. In the meantime, we see a decreased death rate in Canadian women from the late 80s to 2024 of 0.2 fewer deaths per 1,000 women. The majority of new cases of breast cancers are in women 50 plus. Breast cancer in younger women is less common, but when diagnosed, they are often more aggressive. Canadian data suggests breast cancer diagnosis and death vary by race and ethnicity. Different ethnicities compared to white women. The median age at diagnosis is younger in Canada, 52 to 60 years compared to 63 years for white women. The median age at death is also younger, 55 to 64 versus 71 for white women and Japanese. You also see that many ethnicities have a higher proportion of diagnosis at stage 2+. If we look at incidence, There is a higher incidence in Arab and Filipina women aged 40 to 59. In other ethnicities, the incidence is either lower, like in Black women, or the same. Compared to white women over 10 years, some ethnicities have higher breast cancer death. Black women in their 40s have one more cancer death per 1,000 women. In the 60s, you see that First Nation women and Métis women have a higher breast cancer death than white women. Some women compared to white women have a lower breast cancer death. Women from Chinese, Southeast Asian, or South Asian descent. One other fact about breast cancer in Black women: they have a higher proportion of aggressive subtypes of breast cancers, and these cancers have less treatment options. Unfortunately, we don't know if these subtypes would benefit from more frequent or earlier screening. Modeling was attempted to estimate the balance of benefit and harms of breast cancer screening in women of different ethnicities in Canada. But it was not possible at this time because we did not have enough specific data on the link between ethnicity and breast cancer for Canadian women. So the balance between benefit and harms of screening is currently unknown for these women. Let's talk now about breast cancer screening. Just a quick reminder that screening is checking for a disease when there are no symptoms. It is not a diagnostic test. It is not for people that have symptoms like, for example, a lump. And it might be surprising, but screening may have benefits but may also have harms. So what did we try to answer? We had three key questions. The first one was about the effectiveness of screening. So what are the benefits and harms of breast cancer screening in women 40 and older? Then we looked at comparative effectiveness. So the age to start, age to stop screening, the use of different screening tests, and the use of different times between screenings. The third question looked at the values and preferences of women towards breast cancer screening. And all of these was for women not at high risk, and I'm going to define that a little bit later on. When we make our questions, we make sure that we look for outcomes that are meaningful to patients. So what we looked for benefit, for example, some of the things we looked for are decreased stage at diagnosis, less harsh treatment, improved quality of life, and decreased death. We also looked for harms, like additional tests needed to show no disease, or what we call before false positive, biopsies needed to show no disease, harms of treatment, and overdiagnosis, which is a diagnosis of a true cancer that would not have caused any symptoms or problems. Like I said before, we didn't look at screening for women at high risk. We looked at screening for women at average risk or moderately increased risk. We define a moderately increased risk as women with a moderate family history, defined as 1 first-degree relative or 2 second-degree, diagnosed after age 50, or women with dense breasts, category C or D. We use a methodology called GRADE, which is used all over the world, and it's a very transparent methodology, so you will find on our website all the information we used and all the answers we gave to stakeholders' comments, for example. So you could see there were different pieces of the evidence review. So systematic reviews, we also looked at Canadian jurisdictional data, mainly for false positive. There were document submission in the portal, epidemiologic data from Stats Canada, modeling exercise, and all of this went into what we call an evidence to decision framework, which is a big document taking all of it together, and it's available on our website. All of this goes back to the working group for some feedback and judgment, and then to the task force for the draft recommendations. Some say that we used only randomized control trial. For these recommendations, we included a lot of observational studies for many of the outcomes, one modeling study, many more patient values and preferences studies than in 2018. And like I said before, some contextual information and statistics from Statistics Canada. We included the most recent evidence, and we used this evidence in our deliberation. We had a modeling study, a very recent one, and all the latest observational studies. Lastly, we conducted analysis with and without the CNBSS trial, and like other groups in the past, the Evidence Review Synthesis Center found no substantial differences in mortality results with or without this study. Let's look now at the draft recommendations by age group. So who are these recommendations for? They are for women age 40 plus, and we defined women as anyone that was assigned female at birth. That includes cisgender women, non-binary people, and transgender men. These individuals needed to have some breast tissue, so no double mastectomy. And I say again, these do not apply to people that have extensive family history, genetic mutation, or symptoms like a lump. We start with an overarching statement. Breast cancer screening is a personal choice. Women aged 40 to 74 should be provided information about the benefit and harms of screening to make a decision that aligns with their values and preferences. Information should include our age, family history, racial groups, and breast density, if known, may impact benefit and harms of screening. If someone is aware of this information and wants to be screened, they should be offered mammography every 2 to 3 years. So I will stress again that the main message here is that breast cancer screening is a personal choice. Let's start with women 40 to 49. These are the results for women 40-49. For 1,000 women screened over 10 years, you see benefits and you see harms. If you look at breast cancer death prevented, the number vary from 0.27 to 0.94. This is less than one woman out of 1,000 women screened over 10 years that will not die of breast cancer because of screening. For stage 2 or higher, we didn't see any reduction. Overdiagnosis in 2 women out of the 1,000 women screened over 10 years, and there were 368 additional imaging and 55 biopsies. But what about if you start screening at age 40 versus starting screening at age 50? There was no studies that we could use to inform us on this question. So we relied on modeling. Modeling is a computer simulation where you take women that are similar to the population in Canada, and you have these women screened starting at 50 or 40, and you follow them over their lifetime. So the difference between starting at 40, screening every 2 years, or starting at 50, screening over 2 years, informed by the modeling data, is that you would have 1 less stage 3 plus diagnosis if you start at 40, up to 1 less breast cancer death if you start at 40, 2 less chemotherapy treatment, but at the other side you would have 170 more false positive or additional imaging and 16 more biopsies. That you start at 40 or at 50, the number of overdiagnosis over a lifetime stays the same. About patient values and preferences in the 40. When given a scenario with similar numbers as above, our reviews show that the majority may weigh the harms as greater than the benefits. But we do recognize there is variability in patient values and preferences, and that there's a lack of data from a racially diverse population. So what were the considerations in this age group? Compared to older age groups, the likelihood of additional imaging and biopsies is higher. The number of breast cancer deaths avoided is lower, less than 1 over 1,000 women screened over a decade. Overdiagnosis is similar whether you start at 40 or 50. And patient preferences show a preference towards no screening, but this varies. So taking all of this information into account, in the age 40-49, we suggest not to systematically screen with mammography. Because individual values and preferences may differ, those who want to be screened after being informed of the benefit and harms should be offered screening every 2 to 3 years. What about claims we hear that recent studies show a 50% reduction in breast cancer death with screening? So this is what we showed by the 1 over 1,000. The number of deaths out of 1,000 non-screened women would be 2, and out of 1,000 women screened is 1. This is 1 out of 1,000 in absolute risk reduction, which is equivalent to 50% less. This is why we use absolute numbers, because this is much more transparent and easy to grasp. Let's talk about women 50 to 74. So let's look at studies where we were able to separate the data by age groups. These results are still expressed in 1,000 women screened over 10 years. The only difference is that the 70-74 here are screened for 5 years but followed for 10 years. So you can see that there are benefits and harms and that they vary within the age groups. The benefits are usually more frequent as you age, and the harms usually less frequent as you age, except for overdiagnosis where it goes up in the 70-74 because of competing causes of death. As for stage 2 or higher, there was no reduction in the 40 to 59 and no data in the 60 to 74. But what about other outcomes of interest like surgery, radiotherapy, chemotherapy? So there were no studies that could inform us on these outcomes by decades, because the only studies that do report these outcomes are studies where all ages are combined. For surgeries, mastectomies, in RCTs you have more mastectomies in the screen group. In observational studies you had 0.4 less total mastectomy and 0.9 more lumpectomy, so a total of more surgeries in the screen group. For radiotherapy and chemotherapy, unfortunately, there is no observational data. There are in RCTs an increase in radiotherapy in the screen group and a decrease in chemotherapy. Patient values and preferences in the 50 to 74 age group. When given a scenario with numbers similar to the above, a large majority probably think the benefits outweigh the harms. That was shown in our systematic review. But we acknowledge again that there is variability in patient values and preferences. So the considerations for this age group: there is a more favorable balance of benefit and harms. It does improve with age. And informed decision making is still very important. For women 50 to 74, we suggest screening with mammography every 2 to 3 years. Because individual values and preferences may differ, it is important that women aged 50 to 74 have the information about the benefit and harms of screening to make their decision. And then let's talk about women 75 plus. What would be the benefit and harms of stopping screening at 74 versus 79? There was only one non-randomized study to inform this question, so again we looked at modeling. So if you compare starting at 50 and stopping at 74 with screening every 2 years, or doing the same from 50 to 79, regarding stage 3 plus diagnosis, there will be up to 1 less. No difference in breast cancer death prevented. 17 more false positive or additional imaging, and 2 more biopsies. Our recommendation for this age group is we suggest not to screen with mammography. In the ages 75 plus, there is a lack of information, but there is concern that the harms outweigh the benefits if screening continues beyond age 74. What about for women at moderately increased risk? For women with dense breasts, category C or D, we suggest not to use MRI or ultrasound as supplementary screening tests. We did not find any evidence on the benefits of supplemental screening for outcomes important to women, like stages of diagnosis or death. Another group at moderately increased risk are women with a family history. We suggest not to use MRI or ultrasound as supplementary screening tests. We did not find, again, any evidence on the benefit of supplemental screening for outcomes important to women. So for these women, if they are interested in screening, they should refer to the recommendations that correspond to their age group. We recognize that these women have an increased risk of breast cancer and breast cancer death, but we couldn't find any direct evidence, like I said before, on the potential benefit and harms of screening for these women. But we did provide some information about the increased potential benefit for these women using indirect evidence. These calculations have limitations as they assume the same effect of screening in both the average risk and the moderately increased risk groups. We could give an estimate of increased benefits, but we could not estimate harms. They may be similar, increased, or decreased. We join other groups like the USPSTF in calling for more research. We are also calling for more data collection in Canada, so we can be better informed on the impact of screening in Black and other populations of diverse ethnicities, and also better informed on the impact of supplemental screening for those with dense breasts or a family history. Some information about recommendations by other groups. The USPSTF looked at tomosynthesis. They didn't find any studies to inform about many of the benefits we would have liked to know about, but they found there was little to no difference between tomosynthesis and digital mammography in regards to false positive. They also looked at annual screening versus biannual or triannual screening, and they found that it increases harms with uncertain benefit for patient-important outcomes. We are aware of recent recommendations from other Canadian groups. We are unsure what data was used to make these recommendations. We asked for these data and we looked for these data. But what we know is that we did a comprehensive review and looked at many sources of data. Our perspective. We agree that breast cancer is a real and important problem, and tackling this needs more than screening. We believe that a one-size-fits-all approach is not appropriate for Canadian women, particularly given our knowledge of the benefit, harms, and values and preferences of women. To conclude, we recommend that clinicians share the information discussing potential benefit and harms using absolute numbers. We also recommend that women 40 to 74 seek the information they need to make the decision that it's right for them. For programs, we recommend also that they share the information in absolute numbers, and we recommend that they use the number of women able to make an informed decision as a quality metric, and as well that they gather information about ethnicity. We recognize that not everyone has access to a primary care provider. We will provide different types of tools on our website in the coming months. If you want more information, the draft guideline, clinician and public tools, and links to systematic reviews are all available on our website. We do welcome any stakeholders and public comments. We have a portal that is open until August 30th. All comments will be looked at and considered in the final guideline. Thank you for listening. I shared here today a lot of information, but if you still have questions, you can look up our website where all the documentation is available.